Hi, good evening, everyone. Well, it's evening here, so I think it might be morning your time. And thank you so much for joining us for this webinar for the Commonwealth Fund's 2018-19 Harkness Fellowships in Healthcare Policy and Practice. We're thrilled to have the opportunity to talk to you and tell you about the program. I'm joined, I have the great pleasure of being joined by Dr. Jane Hall, who is Professor of Health Economics at the University of Technology, Sydney Business School. And she is also the founding director of the Center for Health Economics Research and Evaluation, Chair. She is, in addition, she is our representative for the Australian Harkness Fellowships Program and represents the program for us on the ground in Australia, and has been instrumental in building the program going back to 1998. So she's very much the face of the Harkness Fellowships in New Zealand. We'll also be joined by Dr. Robin Whitaker, who is a 2010-11 Harkness Fellow in Healthcare Policy and Practice. Robin is a public health physician, and she now is working in research and innovation at Waitemata District Health Board in New Zealand. She's also associate professor at the University of Auckland's National Institute for Health Innovation. And she is an international expert on mobile health, which was the topic of her Harkness Fellowship. And she came with her family, and we'll be able to talk about what that experience was like and how the Harkness Fellowship changed her life. So let me tell you a little bit about the Commonwealth Fund first. The Commonwealth Fund is one of the oldest foundations in America. We're the fourth oldest, actually, established in 1918 by Anna Harkness. And our mission is to promote a high-performing healthcare system that achieves better access to care, improves quality, greater efficiency. And we are also one of the most passionate voices in America for vulnerable populations, including low-income people, people who are uninsured, minority Americans, young children, the elderly, undocumented immigrants. We're unique as well in terms of having an international program in health policy that is designed to spark creative policy thinking across industrialized countries, and to really help us learn from each other, from innovations in policy and practice. And we also do a lot of benchmarking of healthcare systems. Just to give you an idea, a little bit better idea of some of the things the Commonwealth Fund does, we have a major program on insurance access and coverage, and beginning with health reform in 2010, we've been tracking the expansion of coverage, the effectiveness of the health insurance exchanges, the affordability of healthcare, and how health reform has impacted particular populations, whether they be minority Americans, they be older adults. And we also look at how the exchanges and health insurance expansion of coverage is working in terms of small businesses. Another major program of the Commonwealth Fund is around delivery system reform, and looking at some of the innovations that have been sparked by the Affordable Care Act to transform the delivery system. And these include new models of care, such as accountable care organizations, a lot of support towards advanced patient-centered medical homes, and looking at the way some of the new payment reforms are also working to help drive quality and efficiency in the healthcare system. We do a lot of benchmarking U.S. healthcare system performance. We put out national report cards, state report cards on long-term care. One of the areas where I think we're unusual is in terms of trying to translate research and evidence for policymakers. And we hold an annual congressional retreat each year and bring together members of Congress, Republicans and Democrats, for a very intensive briefing. It's kind of a boot camp in health policy on the really complicated issues that they're going to have to deal with in the next session of Congress. We also focus on particular populations. One is what we call high need, high cost patients. These are the 5% of patients that actually consume about 50% of healthcare resources. Patients with multiple chronic illnesses, patients at the end of life, patients in need of health and extensive social care. And we look at the models of care that can provide the highest quality and the greatest efficiency in terms of managing these patients with very complex needs. The other population we focus on is vulnerable patients. And for us, we define these basically as low-income patients. And these might be people without insurance. They might be undocumented immigrants, minority Americans. And they also are often patients that have a lot of not just healthcare needs, but a lot of social care needs. And so we try to look across health and social care. So turning to the Harkness Fellowships, which is the crown, the jewel in the crown for the Commonwealth Fund. The Harkness Fellowships have been operating since 1925. They were modeled after the Rhodes Scholarships, and they really set out to help nurture the next generation of leaders. Since 1998, they have been focused on healthcare policy and practice. And here you can see the countries where we have Harkness Fellowship programs. So initially beginning with the UK, Australia, and New Zealand, those were our original Harkness Fellowship countries going back to 1925. And when the program started to focus on healthcare, we brought in other non-English speaking countries. We have partners across the program who help support the program and co-fund Harkness Fellowships in the countries that you see, and make it possible to now have Harkness Fellows in 8 countries. What can Harkness Fellows expect? Well, first of all, you come to the US for 12 months, so it's kind of a sabbatical. It's the chance to do research on a really important healthcare policy issue, or looking at the delivery system and transformation of the delivery system and innovations. And whatever the issue is that you would pick to work on during your Harkness Fellowship, it has to be an important issue in the US context, but equally important, it's got to be at the top of the policy agenda in your country, in Australia or New Zealand. Fellows gain a very in-depth understanding of the US healthcare system for sure, but there is so much interaction with all the other fellows that fellows learn as much about the other country healthcare systems. Fellows work with leading US policy experts, and not only are they placed with someone who is a national expert in their area of interest, but throughout the year they get to meet with people who really are influential in terms of policy and healthcare delivery system leaders. Fellows get to travel around the US lots. They see firsthand a lot of the innovations. Many fellows do case studies. And they also develop a network of contacts that really is one of the things they take away from the fellowship. And that turns out, I think, for fellows to be an extraordinary network of contacts that they remain in touch with and collaborate with, people they collaborate with for the rest of their careers. But what fellows tell me is, they tell me two things. They tell me that the Harkness Fellowship is life-changing, but they say it's really special because it's a chance to step out of the day-to-day jobs that you have, the deadlines, the meetings, the administrative work, and to really step back and think big about some of the most important challenges in healthcare policy and practice. The Commonwealth Fund is very hands-on with the fellowship. When you get here, we are involved with you all the time. And the Commonwealth Fund is able to really, we think, add value to the fellowships because our staff, we're about 60 people at the fund. Half of those are program area experts, and they are nationally recognized. We do research in-house. About 40% of what we fund is research that we do. So there's a lot of depth in terms of the fund staff expertise that's very available to Harkness Fellows. Harkness Fellows also can connect to all of our grantees, and our grantees are handpicked, and they are doing what is some of the most leading edge work in terms of healthcare policy and health reform. And just being part of the Commonwealth Fund family opens doors for Harkness Fellows, and it's very easy to connect with and talk with and meet with anyone you would want to in the States by saying that you're a Commonwealth Fund Harkness Fellow. The award, I won't spend too much time talking about the award. You can read more about that on the website. It's $130,000 for a single fellow, covers airfare, living allowance, some research travel, all the Harkness seminars, of which I'll talk a little bit more later, health insurance and taxes. If you come with a family, we say that the family supplement is about $60,000. So that's airfare and a living supplement, health insurance, taxes for a fellow, $60,000 if you're coming with a partner and 2 children. We're very family-friendly foundation. So if you have more than 2 children, we will also cover them. You don't have to leave the 3rd child home. Here's just some examples of projects that fellows are doing currently or have just completed in the last year. And you can see the wide range from integration of mental health and primary care to using big data and analytics to transform healthcare, to choosing wisely as a strategy to reduce low-value care, or on the payment side, looking at how bundle payments work and how effective they are in improving efficiency, care coordination, and reducing costs. So it just gives you a sense of the range of projects that are possible. Here are just some examples of placements. Fellows tend to be on the East Coast or the West Coast when they're placed. That's not accidental. That's just tends to be where most the centers of health policy and research are in the country. Fellows are placed in an academic setting, which is probably the most typical, but we always have a fellow or 2 placed at a delivery system, Kaiser Permanente, or at the Institute for Healthcare Improvement in Boston, or in government, such as the Office of the Assistant Secretary for Health. When you apply for the Harkness Fellowship, it's great if you have an idea of where you want to go, who you would most love to work with, but you don't have to have anything arranged. Once fellows are selected, we really spend a lot of time, about 3-4 months, working with each new fellow to help refine the project. Sometimes the projects may even change, but also to think about who would be the best mentor and to give the fellow a chance to explore. We will make recommendations as well, and fellows will talk to maybe 5 or 6 potential mentors till they decide what's the right fit. And it's the fellow's decision. And we think a lot about the families when we do that too. The placements have to really work for the families. And as you can see, none of these placements are bad. I've never had a fellow complain about San Francisco or Boston, I can promise you. And we have fellows, actually the past few years, we've had fellows at Dartmouth Institute in New Hampshire, which has also been a fabulous placement. We've had fellows in Chicago, in Seattle, in North Carolina. So there are more options than I'm showing here, but it's the best fit that we're looking for. And here are just some examples of our mentors, and they really do read like a who's who of U.S. healthcare. And I think the thing that I love about this slide, why I love to get to it and talk about it, is you can see that these mentors have had more than one fellow. And the truth is the mentors love Harkness Fellows. And this is what makes the program work. It's because fellows come to the U.S. to learn all about the U.S. healthcare system, meet with U.S. experts, but it's a two-way learning process. And the mentors love Harkness Fellows because of the expertise they bring about their home country healthcare systems. And it gives us the chance to learn about the Australian healthcare system, the New Zealand healthcare system, the reforms that are underway, where you outperform the US, how you do it, what are some of the innovations underway. So the mentors are thrilled to bring a fellow into their department because of the knowledge, the expertise, and the perspective that you bring to the US healthcare system. We have a structure of meetings throughout the year, the fellowship seminars, and we start off with the orientation. So fellows have already gone to their placements, they've met their mentors, they've gotten settled in, they've got their driver's license and their social security number, and the kids are in school. And they come to Washington for a week in September, very intensive week where we spend time talking about the U.S. healthcare system. They meet with all of the key staff, the senior staff of the Commonwealth Fund. The mentors come in, and the mentors have a full day where they talk about the work they're doing. And then we go on site visits like to Montefiore in the Bronx, which is one of our pioneer ACOs. Fellows also come to the International Symposium in November. So this is a signature event. It's one of our most high-profile events, and it brings together the health ministers from all of the countries that fellows come from. And it's a 2-day event where based on a theme. So this year was big data, last year was bending the cost curve, and health ministers come, senior government officials from all of the countries. It's an invitation only, so it's not that many people, and fellows get to spend a lot of time with their country delegation. I always arrange a breakfast where fellows get to spend an hour or an hour and a half with the delegation, the minister, and the senior government officials from their country. So they learn about what's on their minds, and it gives the fellows a chance to sort of develop a bit of a high profile. This year, we had the great pleasure of having Martin Bowles as our keynote speaker. He was terrific at the November 2016 symposium. Another chance to bring fellows together. In January, we go to IHI in Boston. IHI is world-renowned for quality improvement and implementation science, for the triple aim, and for quality improvement collaboratives, and for all of the innovative work that it's done. And we spend a day there, and we get to really see firsthand what they're doing and how they do it. In Washington, D.C., in March, we have a full week policy briefing. We call it Inside the Beltway, look at policy making, and it definitely lives up to the reputation of making policy is like making sausages. And we meet with all of the key movers and shakers in Washington. From the administration, we had dinner last year with the Assistant Secretary for Health. We meet with for example, Patrick Conway. This year, we had a great time with him, hearing about the Centers for Medicare, Medicaid Innovation. Joe Selby, director of the Patient-Centered Outcomes Research Institute, Carolyn Clancy at the VA. We meet with members of Congress. Interestingly, the past few years, we've been meeting with Congressman Tom Price, who is now our Secretary of Health. We meet with journalists and we meet with lobbyists. Lobbyists are a big part of Washington. So we meet with lobbyists, let's say from pharma or from the Association for Retired Persons, which represents 40 million Americans, and lobbies for them. We also have, as part of the year, a California health policy briefing. And we just came back from that. We started out in Sacramento. California would be the 6th largest economy in the world if it was a standalone country. It's big, and I think it has close to 40 million people. So we meet with the Secretary of Health in California. We get to spend some time this year. We did at Kaiser, which is one of our most interesting, most successful integrated delivery systems. So we met with the CEO and the senior staff there and learned about some of the ways they manage patients with complex needs. We also, at the state level, met with the state Senate President Pro Tem, Kevin DeLeon. He leads, it's a Democrat-led state Senate, and he told us about what's on their policy agenda and how they're dealing with repeal and replace. And then we went to spend a day in Silicon Valley at Google, hearing about some of their latest ventures, such as Google DeepMind, and went to visit a bunch of health entrepreneurs in Silicon Valley to learn kind of about some of the next things that are really in the pipeline around artificial intelligence and assistive technologies, and some of the mHealth technologies. And throughout the year, we have leadership dinners where we get to spend, these are really special. We pick a very nice restaurant, lots of good food, lots of good wine, and we spend the evening with someone who has been influential in changing either the US healthcare system or another healthcare system. And they talk very candidly about their experiences and what they think it takes to be a leader, and some of the lessons that they learned that they can pass on. That's all the fun part. There's actually some work that goes with the fellowship, and that includes doing a research project. And at the end, the deliverable is a peer-reviewed journal article, or for fellows that maybe come out of a government background, senior government policy position, theirs could be a report to the health minister and senior government officials. These are recent, very recent Harkness Fellows publications. As you can see, they're incredibly impressive, and many published in top-tier journals. Here's just some examples of where fellows have moved, positions they've moved into following the Harkness Fellowship. Fellows have been very effective at leveraging the Harkness Fellowship and moving into positions of influence when they return home. And we've seen fellows both in government and in academia and in the delivery system take on leadership roles in all countries. We try to bring the fellows back together every couple of years. So this is our 2014 Harkness alumni event in Washington. And it's a great opportunity to catch up with fellows, but also for them to present. In this case, they came to Washington and they presented to the senior government officials in the Obama administration on innovations in their home countries that we could learn from for our health reform. We also have an alumni network and platform to connect alumni, and we're actually enriching that to make it easier for Harkness Fellows to collaborate across countries. We've done a few evaluations of the program, and we did a 10-year one a few years ago. And I think the key points to take out of this are that 5 and 10 years out of the fellowship, Harkness Fellows are collaborating with other fellows and with their mentors. 70% of them are still doing work with other fellows from other countries, other years, and their mentors and other US colleagues. 1/3 were recognized as national leaders in policy, academia, and the delivery system. And maybe the one that warms my heart is the last bullet. Over 90% said that the fellowship was extremely or very valuable to their careers. So the fellowship is about fellows. It's also about families. It seems crazy to come over to the US with, a partner and 3 kids and get them all settled in school and get everyone established. And you'd think that would be a recipe for disaster. But the truth of the matter is families have had the most wonderful experiences. Kids have loved a year in a US school. They've made lots of friends, and we have many examples of the kids as they grow up coming back and spending the summer with some of their friends, and their friends joining them in their home countries. So it seems to be a wonderful chance for families to have an experience together as well. And who should apply? These are the more technical criteria, but basically we're interested in people who are passionate about healthcare policy, research, practice, and really want to make a difference. We're looking for people who really want to take on leadership roles. And deadline September 5th for receipt of applications from Australia, New Zealand. The application is online. Fellows, absolutely, I would encourage you, if you have any question, to contact myself. And certainly in Australia, Jane Hall has been wonderfully generous helping fellows in terms of thinking about their fellowship project ideas and answering questions about the fellowship, and she'll talk a bit more later. So now I'm just going to, I don't want to go on too long because I really want to turn to Jane Hall and Robin Whitaker, but I'll just say a couple things about U.S. health reform, which may help you think about, just to help you maybe think about a project if you're applying. So just a few words about the U.S. healthcare system and how the Affordable Care Act has tried to address some of the challenges that we faced. So why even do health reform, and what were the really big problems that motivated that? I think one to start with, and you're all probably familiar with, is that unlike your countries, we don't have universal health insurance. And prior to the Affordable Care Act, about 21% of adults were uninsured at some point in the past year. And then we have a category of people who may have insurance, but we would recognize them as being underinsured, where the insurance really didn't protect them. And about 18% of people fell into that. And those were people who, They may have had a kind of insurance that had such a high deductible that they never got to use it, and the out-of-pocket costs prevented them from seeking care. Or the insurance may have even had caps, annual cap on what it would pay, or a lifetime cap for a condition. So we saw a lot of people without good financial protection. Spending has been an ongoing issue in the U.S. healthcare system. The U.S. is an outlier. We spend more than any other country in the world on healthcare, and we have been the clear spender in terms of percent of GDP and the per capita spending on healthcare, and probably driven mostly by prices and also that we have a very high use of expensive technologies. So with all that spending, we don't necessarily get the best outcomes. And if we're looking at mortality amenable to healthcare, the graph shows that this is avoidable mortality if people had got timely and effective care. And you could see that of these countries, the US ranks the last, despite spending the most. So in terms of the value equation, we haven't done it. So those are the problems. And now I'll just very quickly mention some of the things that the Affordable Care Act tried to do, with the caveat that it is an enormous health reform. So I'll only be touching on some of the high points. So thinking about the ACA, easiest to think about it in two buckets. So the first goal was to expand health insurance coverage to the uninsured. The second goal was to try and transform the delivery system. So we have what I think would be recognized as one of the most fragmented delivery systems, and one that was geared very much to acute, expensive care and not to prevention and to population health. So how have we done? So the ACA has been impressive in expanding health insurance coverage. Since late 2013, the uninsured rate has decreased by about 40%. That's about 20 million people which having coverage. And that was done through subsidies to people who were low income, but also to middle class Americans. Insurance is really expensive here, and a family of 4 with an average income would have a hard time affording insurance without some help. And the other way we expanded coverage was through the expansion of Medicaid, which is our governmental health insurance program that is a federal and state program, and that's for the very poor. And on the delivery system side, one of the new models of care that has been rolled out as a result of the ACA is something called accountable care organizations. And an accountable care organization, there are many different models of them, brings together providers, a network of providers. They come together voluntarily with insurers. They bear risk for the care that they're going to deliver, and they take care of a population, and they share in the risk, and they also can share in cost savings based on improved quality and improved cost, and they're benchmarked. So the goal of them is really to provide more efficient, better coordinated care to a population of patients. And here you can see where there are, and they're now close to 1,000 ACOs, and half of them are Medicare driven, the other half private commercial insurance. So it's a model of care that really people have seen as a great opportunity for trying to change the system and deliver care that is more value oriented. We also have a whole lot of payment incentives that went into place with the ACA, including to reduce readmissions and reduce hospital-acquired infections, to encourage the adoption of health information technology, but incentives as well, such as bundle payments for maybe hip replacements, knee replacements. And the goal of the payment reforms is really changes from paying for volume, which has been the way the system was set up, fee for service, and move us to paying for value. And I think one payment reform that has had a tremendous effect is on the adoption of electronic health records, where doctors and hospitals initially received incentives, financial incentives, to adopt electronic health records. We were way behind Australia and New Zealand, literally 20 years behind. You were so much ahead of us. But you can see, if you look at the graph, how wonderfully successful that the incentives and the program has been. It was called the High Tech Act, to encourage the adoption of health information technology in the US. So what's next? You've probably heard that we had an election here in the US. We have new president, new administration, and they were very much committed to the notion of repeal and replace the Affordable Care Act. On May 4th, the House of Representatives passed the Republican American Health Care Act, and it would scale back the insurance coverage and subsidies, make large cuts to the Medicaid program. The Congressional Budget Office hasn't analyzed it and its full impact, but an earlier version said that it would probably lead to about 24 million Americans losing their insurance, and it would reduce government spending on healthcare by about $1 trillion over 10 years. However, it hasn't been passed in the Senate. It faces quite a number of hurdles before it would become law. And it's not clear what will happen, what agreement will come out of both the Senate and the House ultimately, or what the president might try and do in the meantime in terms of health reform. But we also don't know really clearly where the new administration stands on the delivery system reforms. There seems to be more bipartisan support for that than other elements of the Affordable Care Act. So that said, it's actually a fascinating time to look at healthcare and policy in the US. There's a lot to evaluate from the ACA, and I think a lot to also be looking at some of the new options that are going to be put on the table. So I think I really will stop now, and it's a great privilege to turn over first to Dr. Jane Hall, and then to Dr. Robin Whitaker. Jane, who will talk about maybe why you would do a Harkness Fellowship and what the value of it might be and what you might bring back. And Robin has been so generous as to say that she will share with us her own experience as a Harkness Fellow. So let me turn over to Jane.
Thank you very much, Robin. Is that working, Sarah? Am I on? Yes. Okay, so I think you can see me as well. Well, good morning, everyone, and thanks for joining us this morning. Thanks, Robin. As Robin said, I've been involved with the Harkness Fellowship Program for some time now, and I just want to say what a pleasure it's been and how wonderful to see how it's developed and what a great experience it offers to anyone who is fortunate enough to be awarded a fellowship. I I guess you might be sitting there at the moment and saying, well, what are we going to learn from the US, given the state that they're in and the issues around universal coverage, which are no longer issues in Australia or New Zealand. One thing to say is that this is such a historic time, and to be in the US when these things are happening is very special. I remember I was there when the Affordable Care Act was passed and watching it with Uwe Reinhardt, and just that sense of being caught up in history is something that you will never forget. But more seriously, what can our countries learn from the US? There's an awful lot going on in terms of delivery system reform, again, as Robin has said. And I think the big issues that come out for us really are summarised by value-driven healthcare. And it's easy from this distance to think of the US as one health system, but of course there are many, many different health systems and therefore many different opportunities for innovation and reform within various components of the overall US system. I think the sorts of things that our countries are trying to explore and make progress on are around funding models, whether that be bundled care, pricing incentives for quality and safety, the development of integrated care programs, and that ties up, of course, with funding issues, the experience of accountable care organisations. I think increasingly there's interest in the use of big data and data analytics and how that can be built into day-to-day health service delivery management. I think just perhaps one other thing to add is how important the Commonwealth Fund has been in developing what we do with health system performance assessment and comparisons across international systems. And what you learn from that is something that will be used in your home countries as well. And finally, I'm just going to finish by saying it's not just the research project, although that's going to be important, challenging and interesting. It's also the interaction and the development of networks with Harkness Fellows from across that range of countries. And what I've seen is that it's not just the people who are in your cohort, but you become part of the Harkness alumni, and that is a really strong set of connections, a really strong network. So let me, before I hand over to Robin Whitaker, to just say, please don't hesitate to contact me if you have any questions, particularly about framing your research proposal or indeed other aspects of the application process. Please get in touch. My email address is on the screen. I'm always happy to talk to people, not always sitting at the end of my office phone, so email me and we'll set up a time to talk. I'm going to pass over to Robin because I'm sure she'll be able to give you a much better sense of what an exciting opportunity this is than I can. Over to you, Robin.
Thanks very much, Jane, and hi everybody. So I'm just going to tell you briefly a little bit about my experiences as a Harkness Fellow, and I'm very happy to talk to anyone in more detail about this. So I did the fellowship in 2010-11, which is a little while ago now, and I just really want to encourage everyone because it was the most fantastic experience for myself and my family. So I'll tell you a little bit about why it was so good. I took my whole family with me. We went to Washington, D.C. So I took my husband and two daughters. One was 3 and one was 11 when we left. And it was a fantastic experience for the whole family, actually. We all had a wonderful time. My oldest daughter spent a whole year in middle school in Washington, D.C., and she had a fantastic time. She built up a whole network of friends that she's still in touch with. And my youngest went a couple of days to preschool, and my husband actually took some time off work. He was ready to do that in his career, so he actually left his job and then he went home early to start a new job. So he stayed at home with my youngest as well, and we made great friends as families. We made great friends with our neighbours, who were all very welcoming. and we still keep in touch with them and go and visit them every now and then as well. So it is a big deal taking your family that far away to the other side of the world, and it does require quite a bit of logistics and a bit of research, but there's an awful lot of information online that can help you to do this. So we read up a lot about schools before we went, which helped us to decide where to live, and we organised our house through sabbatical.com. And that all worked out really well for us. But there is this great network of past Harkness Fellows who will help you with all of that information before you go, to help you to set out the logistics. Work-wise, it was a fantastic experience. I was based in one of the Department of Health and Human Services, so the federal level health government organisation, and it was fascinating. It would be even more so now, but it was fascinating at the time. We got very close to an all of government shutdown when I was there, actually. So it was really interesting to learn about the US health system, but also being a Harkness Fellow just opens all these doors to meet the most amazing network of people while you're there. So you can ring up almost anyone and say you're a Harkness Fellow, and they will open their door and spend time with you. So I made a fantastic network of people in my field. My research was around mHealth, or mobile health, which was really just taking off at the time in the US. And I made the most amazing network of people, academics, government and others working in the field of mHealth. And I still have that network, and I still visit the US a lot, and I do research still with US partners. I'm on some NIH grants that have all stemmed from that time and those networks that I have maintained. They were very interested in what I was doing as well, so I got to do an awful lot of talks and go to a lot of conferences while I was there and talk about our New Zealand research in mHealth, which was a great thing. So as part of the fellowship, of course, you get brought together every sort of 6 to 8 weeks with all of the other fellows who are there at the same time. So there was a big class when I did it. We had 16 from all over the world, and I still maintain a lot of those friends as well. So just recently had a friend from the UK who was the Harkness Fellow come and visit us. We talked her into marrying a Kiwi. So we've managed to keep in touch with her, but also other colleagues in England and Australia in particular that I still keep in touch with and go and visit when I'm away, and Norway too. Just visited a Harkness Fellow in Norway when I was there recently. So it's a great international network and a great US network that have really done. The US network in particular has been great for my academic career. That I've managed to keep that up. I get invited to sit on boards and scientific committees and NIH grants through that US network that I maintain. And I guess the other thing is about coming back to New Zealand and what it does for your career. So as Robin said, there is a great New Zealand alumni of previous fellows that you sort of get included into this wonderful group of people in New Zealand or in Australia, of course, once you've done the fellowship. And so I came back and, as a lot of people do, take a slightly different step, decide that you want to take a bit of a step up or move in a slightly different way, because that's one of the things the fellowship allows you, is to have that time out from your current career to think about what you really want to do and where you want to go. And so I came back and moved into a district health board, working for a previous Harkness Fellow, Dale Bramley, who's the CEO, and then with another Harkness alumni that Dale employed, Penny Andrew. And between the three of us, we've now set up a new institute for innovation and improvement at Waitemata District Health Board, where Penny is the director and I'm the clinical director of innovation. And so that alumni was really important in that we all knew roughly what we wanted to do, where we were going, and we knew we had that shared experience that we could build on. And so the three of us were quite that relationship was quite important in going forward and building this institute within Waitemata. And now we continue to work together to make a big difference is what we're trying to do. We're trying to learn from the best international examples of innovation and improvement around the world and try and implement these quickly, rapidly, nimbly in our DHB, see what works and what doesn't work, continue to refine them in improvement and then move on. So it has been a really big factor in my ongoing career back at home as well. So I really encourage you all to think about applying, to consider, that it is a really big move, but that it can be a fantastic move. It can be a real step change in your life and your career. It's a big thing if you've got a family, but it certainly can be done. And unfortunately, she was 3, she's now 9, doesn't really remember it very well, but she was totally immersed. She was a little American, but she doesn't remember so much now. But my now 18-year-old totally remembers it, feels that it was a wonderful experience for her. For me, it actually made a big difference to her schooling. It was a very good time for her, and she really stepped up in terms of her schooling. And she still has these wonderful friends, and she has these great memories, and we have great memories as a family of all the things that we did while we were living in the US. So I really encourage people to apply, to think about applying. But one of the things to think about is doing it at the right point in your career, and that's what Robin and others, other fellows and people from the selection committees are really good at helping you to think about, what is the right point in your career, and helping you with that. And any of us past fellows are always really open to helping people with their applications, to telling you more about how it worked for us, but just reviewing your proposals and your applications, and then talking to you about how to frame that and what it might mean for you in terms of your career, and so how to best approach it. So don't be shy about contacting anyone and asking if they would help you, because even if they are not able to, they'll put you in touch with someone else who can, I'm sure. So that's probably enough talking for me, but I'm very happy to answer questions or to talk to people on the phone or by email, so do feel free to get in touch with me.
Well, thanks so very much, Jane and Robin. That was wonderful. And just thinking about what Robin had said, we actually have close to 250 Harkness alumni now. I can't believe it. And all of them are on our website, so you can look across all the years and countries, and their contact information is there. So fellows, we try very hard to keep it up to date, current contact information. And I know from experience that Harkness fellows are wonderfully enthusiastic and encouraging to people who want to apply. So you should feel free to do that. You can actually sort fellows by country and by project area. So you can get a sense of who might have done something in the area that you're interested in, if that's, if you want to ask them about that too. So I am going to see if anyone has any questions. You can please enter them in, and I think they show up on my screen. And we're really happy to try and answer them. So feel free to ask about the program, project, eligibility, families, budget. Okay, first question has come up. Thank you. Is there a limit to the fellows from each country? There actually is an allocation for each country, and it's just based on funding. So there's one fellow selected each year from Australia, one fellow from New Zealand, one from France, one from Norway, 2 from Germany, 2 from the Netherlands, 4 from the UK, and 1 from Canada. we hoping everyone can still hear me. I'm getting a message about my internet connection. We also put up on the website, when you go to look for the application, we have some frequently asked questions. So that can tell you a bit more about the Harkness Fellowship. And then we have suggested themes for Harkness projects. And that might be really helpful because we identify some of the areas that the fund is most involved in and the kinds of projects that we're supporting. Often a fellow will, an applicant will end up doing a project working with a Commonwealth Fund grantee. So the mentor will be a fund grantee and they'll have a big project and the Harkness Fellow will carve out a piece of that for themselves. And that works very, very well. When are successful applicants notified? So the application deadline is September 5th. We do the interviews the first week of December, and applicants, believe it or not, applicants who are interviewed, who are shortlisted and interviewed, find out the day of the interview. So notification in Australia and New Zealand would be the beginning of December for the following September. Have there been any fellowships looking at Indigenous health issues? Absolutely. So fellows have looked at disparities. They've looked at particularly Indigenous health. We've had some really fine publications looking across countries, US, New Zealand, Canada, looking at programs to improve health for Indigenous populations. So yes, that's been an important theme, absolutely.
The train.
It's like we just had a cement mixer come through the room. Okay, well, if we're available for questions by email. Very happy to set up a call. How many applications are received each year? Let me answer that one before we sign off then. So it varies, and it varies by country and it varies by year. But it's, in Australia and New Zealand, we might get 10 applications. Could be 8 to 10 applications in a year. That would be fairly typical, I think. And I think it's really worth applying in terms of having a really good chance. We don't get hundreds of applications in any country, even in the UK where the fellowship we have the most fellowship positions, and the fellowship has been running the longest, because it really takes, someone has to have the background, the qualifications to apply, but also the timing is so particular when you can find that window of opportunity. So it's worth applying in the sense that, of course, it takes, a lot of time to write an application, but there aren't that many. Every application gets full consideration, and people have, just in terms of numbers, have a good chance. Okay, well, I think we'll close for now. And what I'd like to say is we're available by email. Jane and Robin have been very gracious and are very happy to answer questions and set up calls. And again, previous fellows that you can find on the website will be very encouraging and helpful. Any question that you have, feel free to contact us. And again, the website has quite a lot of information. It has examples of applications, successful applications, so you can see kind of what a good application looks like. The research proposal, we call it a preliminary proposal in the application because we understand it's hard to write an application in a project proposal from the other side of the world for the U.S. healthcare context. So we know the applications will likely change or at least be refined somewhat when fellows are selected. So that's not a problem. You want to write something that is a robust proposal, but we also understand it's hard to know everything about the U.S. healthcare system from afar. So don't worry too much about that. And if you have any questions about whether a project idea is a good fit or not a good fit, just feel free to send me an email, and I'll give you a quick take on that, and maybe even some suggestions about who you might want to talk to as you're developing it. So let me thank everyone for your time, for joining us, to my wonderful panel, and I hope that all of you are interested in applying for Harkness Fellowship. We would really look forward to hearing from you and to getting an application. So thanks so much for your interest, and have a great day.
Indeed.
Thanks,
Thank you, Robin.
Thank you.
Bye-bye.